We have here a patient who attended with otitis externa of their right ear. Otitis externa is an umbrella term given to an infection or inflammation involving the outer ear. And the outer ear consists of the pinna, which is the flaps of cartilage we have on either side of our head, the ear canal itself, and the outermost layer of the eardrum. So our eardrum, also known as a tympanic membrane, is made up of 3 layers. The outermost layer, so the lateral layer, is made up of the epidermis skin, which also lines the ear canal. You've got the innermost layer, so the medial layer, that's the mucosal layer. So the mucosal skin is a skin that is secretory, so it secretes mucus, similar to the mucosa skin that lines into our nose. And then you've got a fibrous layer, a middle layer, and that's what gives the eardrum its strength and rigidity. So if you've got an infection of the outermost layer of the eardrum, the ear canal, or the flap of cartilage on either side of our ears, we call that otitis externa. Now, more specifically, this patient has got granular myringitis. So myringitis is when it's the eardrum itself, more localized infection of the eardrum. And you can see the granular tissue at the bottom, those red bumps. So granulation tissue is inflammatory tissue. So whenever you see inflammatory tissue, you know there's been some inflammation, there's been some trauma, the ear or the body, wherever you may see the granulation tissue, it's trying to heal. And quite often though, you can develop granulation tissue, which is connective tissue that has its own supply of blood capillaries. And it gives this very bumpy, moist red, fleshy appearance. So this patient is obviously going to need some medication. Sometimes though, that granulation tissue doesn't heal just by using antibiotic drops, and sometimes ENT need to cauterize the ear. So the concept behind cauterizing the ear, they use silver nitrate to cauterize it, is essentially you're burning away this granulation tissue in the hope that when the ear then re-heals itself again, so it has a second attempt, that the granulation tissue doesn't reform. And I've seen it done a couple of times, and it's a very skillful procedure done by ENT specialists and consultants. So now I've removed most of the discharge off the eardrum, and we are going to get some out afterwards, but here I'm now going to use the Curette to help elevate and retract this crusted layer of skin off the ear canal. So this skin has been coated by some of the discharge in the ear, and that discharge is then solidified and it's crystallized the skin, and you can see that we've lifted the entire blanket and thick layer of skin that was sitting on the anterior canal, or the front part. And I wouldn't be able to have done this with the previous Jobson horn I was using, so this is the new Curette that I've developed. It's got a tapered tip, it's also got a curvature that mimics the curvature of the ear canal. It's worked really, really well there. It doesn't mean that you can just go in the ear and start gliding around, because if you do it in the wrong regions and you don't get the angulation right, then it's going to cause discomfort to the patient, particularly when you're encroaching on the inner 2/3 of the ear canal. So you've got to be very careful. And you'll see another example of me using the Curette, and there's no trauma caused whatsoever to the ear canal. You can see it just glided, there's no friction there, there's no blistering. And it's not to say that if I do it again there won't be some blistering whenever you peel skin, there's always a chance, but the design of the Curette is such that it's designed to minimise any trauma caused to the patient. So I've just reverted to the micro jaw forceps, and I've rotated the forceps so the jaws are more at 3 and 9 o'clock as opposed to 12 and 6 o'clock. I've got a good grip there. I'm just bringing this out into a very dry skin to get the entrance eczema psoriasis appearance. You can see this nice healthy ear canal underneath this skin. The fogging is due to the patient's otitis externa, so when there's an infection, your body response is to you have inflammation, which then increases the temperature in an attempt to kind of fight off the infection, and that can cause condensation to the lens of the endoscope. But as soon as you enter with the suction probe, it demists and fogs the lens of the endoscope. So the purpose of removing this dead skin is just to reveal the healthier underlying skin, and it's probably unlikely to come out by itself. This is really a did. And when this patient does begin to use the topical antibiotics, it can penetrate and make contact with the surface of the epidermis layer of the ear canal. Now, we're not going to get every little aspect, guys. There's always going to be bits and bobs here, but I'm going to try to remove as much as possible. At the base, it is quite a deer, so it's quite tricky. But already you can see the difference between this patient's ear on attending and at this halfway stage, or less than this, 1/3 of the stage. So we are going to spend a bit more time mopping up. I'm using the fine end suction probe, and this is going to be quite revealing in a minute. You're going to see a lot of damp, dead skin. So we call this squams of skin. And it's going to away. It's hidden in the inferior and anterior recess. Just, as I said, bend the tip of the fine end to get access. Otherwise, I'd make contact with the front part of the ear canal. You can see I'm pretty close to it, even with the tip of the fine end being angled. But I want to avoid that because it is very sensitive. And I know firsthand because I've had that part of my ear poked before and it was not very nice and not very comfortable. So just got a piece out there. I'm just going to go back in to extract the rest. So that granular myringitis is mainly affecting what we call the posterior quadrant. Sorry, not posterior, inferior quadrant. The south, if you're looking at a compass, the southern hemisphere. It looks slightly bulged there as well. So there might be some middle ear pathology involvement as well. So the plan of action is written to this patient's GP. I'm going to follow them up, and if there's no improvement after the medication, I'm going to get an ENT referral requested for further investigation and treatment. Slowly peeling that away. The tail end of that is just block the suction probe there. Just gave it a little wriggle. The tail end of that is attached to the eardrum. Be really gentle, as in bringing the suction probe away. I want to go sideways. I don't want to go towards the eardrum any further. And there's just some damp, dead skin on the posterior superior quadrant. So northwest part of the ear. I'm just trying to, again, peel downwards. I don't want to extend the suction probe any further. I don't want to dig into the eardrum. I want to come away and down, so gliding downwards to make minimal contact. I'm really, really pleased with that. There's another bit of skin just there. So in terms of the eardrum, I'm very pleased with that. But yeah, sometimes that bulge at the bottom, it's the granulation tissue is hiding possibly something a bit more serious underneath it, right? It's called a glomus tumor, so it's a vascular mass that can develop normally, as I said, at the bottom part of the eardrum, but this is behind the eardrum. We call it the rising sun sign. You get a blushing or redness in the base, but a typical symptom of that is pulsatile tinnitus if it's glomus tumor. I mean, there are other different middle ear vascular masses that can be present that doesn't present in pulsatile tinnitus. So pulsatile tinnitus is when you hear the rhythmic beat of that vascular mass hitting against the inside of the eardrum. So again, I'm just using the right Curette, just gliding, almost like a wallpaper stripper. That's the way it kind of looks on the screen, really. But you've got to be so careful because as you glide, you're still going to account for the curvature of the ear. So our ear canals, there is a slight incline upwards. The average is 32 degrees, but there's no such thing as averages in the ear. Everyone's ears is so unique. But so as you're gliding, you've got to account for that upwards trajectory, so you've got to glide upwards. Otherwise, the tip of that Curette is going to bump against the wall and graze it. But you can see we did a pretty good job. I'm pretty pleased with that. There's no bruising, hematoma there, or any abrasion caused. Obviously, we don't want to cause any micro abrasions because that's just going to possibly lead to an infection as well. So some crusted skin here. Again, I'm gliding across the surface only. It's really crystallizing. One of the patient's symptoms are itchiness in the ear. And no doubt that's not going to be helpful. Just crusted dead skin. They felt the skin to be very tight in the ear. Which, of course, when you've got this thick layer of crystallized skin around the ear canal, when you move your jaw and your ear moves, you can feel that. So again, just going to see if the Curette helps here. I'm trying to just very thin layer. I think I've got underneath it now. And you've got to be controlled. You've seen there that I applied a lot of pressure upwards and the Curette came over the top of the skin. You don't want to let that Curette then flail around in the ear canal, so you've got to have full control, just like that. You've got to be prepared when the Curette is no longer underneath the skin, because that force, that pressure you're applying, then means that when the Curette leverages over the dead skin, there's no support for it. It can just flare in the ear and hit the delicate structures. So you can see that's just helped with this skin at the bottom as well. So sometimes I can around your ear canal. Just encrusted bits. If it's coming away, brilliant. If not, I'm not too concerned by this. This isn't the sensitive part of the ear, but because it's quite crusted, I had something to leverage onto there. This is the posterior canal wall, so again on the bony part, I'm angling the suction probe away, you can see, towards the eardrum. I don't want to angle the suction probe, if possible, towards that direction. I want to glide and go away. I don't know about you, whenever I see granulation tissue, the hairs at the back of my neck do stand up. There's something about the appearance of it. I had a patient, I'll try and upload the video. It's a short video, in fact it was a non-procedural video. It's a diagnostic video. It's a patient who attended with serous otitis media, so another name for middle ear effusion, so there's fluid buildup. So I see the colour here of the skin. I thought there was some, it's a bit darker shading, I thought there was some coating, but it's not. It's just a bit darker there, so there could be a bit of inflammation there possibly. And I got them to do the valsalva just to confirm the presence of middle ear effusion. If there's middle ear effusion at its early stage or resolving, so when you've got fluid behind the ear, get them to do the valsalva just gently. You're essentially forcing air up the eustachian tube into the middle ear cavity. You can get some air bubbles and it can move around in the fluid. And the patient said it looked like tadpoles and couldn't watch it. So we airdropped the video, and when they watched it back, they said, no, don't watch this. It made them kind of a bit nauseous. It just gave them that appearance of tadpoles behind the eardrum, which is obviously a bit gross. So I'm just mopping up near the entrance here. So I'm just with the Curette now, I'm coming backwards. With the design of the Curette, you can also start separating skin if you go in the reverse. Not as effective as when you go forwards, but that tip is, as I say, taping, and with the opening the hole, the inside, you can see it really there. It can go underneath. So this is more really external part of the ear. There's no trauma across the ear canal, it's really healthy. Of course you're going to get bits and bobs here and there. I've just used that suction there, not to remove anything, but just to get